We'll move on with Raghu's talk on eye socket. It's all about the base, tackling complications of the orbital spherical implant.
Yeah. Thank you everyone for turning up for the first session of the day, and thanks Sajni for inviting me to be part of the IC. So I'll be talking about socket complications, some of my cases and some from others, as always happens. So this is how it was in 1848 when this is almost like a subtotal exenteration without anesthesia. So this is almost stayed the same up to about 265 years after 1848. So only in the second half of the 19th century we actually moved on to do enucleations and in a systematic manner. So earliest evidence of enucleations are like early Egyptians during mummification would remove the eyes and fill it up with the orbit with wax and precious stones to simulate the iris. And there is some evidence that around 500 BC, Egyptians and Roman priests made clay prostheses to be worn on disfigured globes. The clay prosthesis was attached to a ball of cloth, and it's similar to size of an empty socket, and painted and held in place with a thong. So no records to show how enucleations were performed at that time, but we gradually progressed to what we now do, enucleation or evisceration with different implants. So an ophthalmic socket. So what is the purpose of reconstructing a socket? Is basically removal of an eye and the subsequent management of the socket, and it needs a close collaboration between the surgeon as well as the ocularist, because it's good to have a good trained ocularists, so that they understand what is required of a particular socket, and they give the feedback to the surgeons to what is to be required. So so goals of a nucleation or evisceration is a healthy and a comfortable socket free of discharge, which can be fitted with a well fitting stable ocular processes that mimics the fellow eye in appearance and movement as far as possible. It's never going to be 100%, but as far as possible. A symmetrical appearance without any enophthalmos or an upper eyelid sulcus deformity, and an absence of a upper or lower lid malposition, and a normal eyelid closure over a ocular process, because the patient wants to seem normal whenever he's talking to somebody and blinking. So indications for enucleation evisceration, it has been the same for many decades now. Painful blind eye following a failed retinal detachment surgery, or a rubeotic glaucoma, or anterior staphyloma, all those things are indications. A blind unsightly eye, they want it for a cosmetic correction, or an intraocular tumor like retinoblastoma or a choroidal melanoma, where that is the only play, so that will actually give the patient a cure for the disease. And severe irreparable trauma in ocular trauma, as far as possible we try to retain the eye because of the psychological reasons for it, but if it is unsalvageable, then it is better to do a evisceration at same sitting and go ahead with the thing. So the concept of post-enucleation evisceration socket syndrome. So basically, about 2 to 3 decades ago, they were not putting in implants when they're putting in the in children, when they were removing the enucleating the eyes. They were not putting in the implants. So what that does is, it over time, if you put a prosthesis over this empty socket, there would be a deepening of the upper eyelid sulcus, variable amounts of upper eyelid dysfunction like a lag ophthalmos, a severe ptosis, and stretching of the lower lid, because as you can see in the schematic diagram here, that it is pushing the lower lid down. So the stretching of the lower lid, and then finally ectropion develops, and that further reduces the fornix, and then sets up a vicious cycle of that, and then the socket is no longer able to hold the prosthesis there. So I just want to give like what all complications can happen during these cases. So this is a case that we had. It was a panophthalmitis, and we did and it was painful blind eye, and we did a evisceration with implant. But about 2 weeks out, she still had the schemosis, and the conformer that we had put was not holding up. So what we did was, we put a fornix forming sutures so that the chemosis would drain out, and then finally she was ready for a, permanent ocular prosthesis. Uh, So there's this patient also, there's one, she had a post enucleation socket syndrome. She had a road traffic accident with a avulsion injury of the lower lid, and the lower lid was reconstructed. They removed the eyeball, but they did not put a implant at that time. And then they put a prosthesis over an empty socket that caused her the whatever I described in the previous slides. So basically, there is volume loss and the inferior fornix shortening, and the prosthesis was not holding up. So and she was very upset with the way it was looking. And then so what we did was we put in an implant and then used fornix forming sutures, and also tightened the lower lid, because the lower lid was an avulsion injury, so it was sagging down. So even tightened lateral tarsal strip procedure was done, and we tightened the lower lid as well. And as you can see, we have a reasonably symmetrical look on both sides. So this patient was from an overseas patient who came, who had a post bevacizumab injection, panophthalmitis, and he was in extreme pain. So we went ahead and did the went and did the evisceration, and after about a week post the evisceration, the infection did the conjunctiva was not very healthy, and that was getting reinfected. So we had to go in for a debridement every 3 days, so that the slough would go, and then we were treating it topically as well. And but eventually there was no extrusion, because there was basically the tissues, the sclera, as well as the scleral melting happening, and as well as the conjunctiva was not very healthy. So that's the reason why it was not healing. So basically we had to do a little hand holding, and we couldn't remove the tumor, remove the implant, because the patient was from overseas, so we didn't know how the patient would, whether the patient would be able to come back or not. But eventually it settled down, and we could put a full size prosthesis and reasonably good symmetry. So this is another patient who did not have a implant put at when he was a kid. He had a retinoblastoma, post retinoblastoma. He had a radiation as well, and is a severely contracted socket. And he did not have implant, and no prosthesis would fit there, because there's a severe ectropion as well. So initially we thought the best thing for both the volume as well as the surface reconstruction is basically a dermis fat graft, which would give some surface as well along with the volume. So we did the first procedure thinking that it would be the one procedure that would be required, and did a fornix forming sutures for both the upper and lower eyelids, lower fornix. And but the problem was that it was the lower fornix was not enough, and then we had to do a second surgery at a later stage to do a mucous membrane grafting. And so you can see the graft that is put in the lower lid, and we did that. Sorry. So this is after the surgery, after about 3-4 months after the first surgery. We could put a reasonably sized prosthesis, which is good, giving good symmetry. He also had nystagmus and other things as well. So it was a little challenging, but our ocularist did a very good job of putting a good prosthesis. So this is the first time I had seen such a case in my life. So I've never seen this ever. So there was this 27-year-old man who came with an infected socket with a foul-smelling mucopurulent discharge. But his main issue was not the discharge or the foul-smelling mucopurulent. His main thing was cosmetically it was not looking good. He's 27 years old, so I can understand why that is the most pressing problem. And he's had history of multiple surgeries, and the last one about 10 years back when he was about 17 years. So the history was that he had retinoblastoma, and they did a right eye enucleation at the age of 3, but they did not put an implant at that age. And when he was around 14, they put a secondary orbital implantation then after that there was exposure of that implant, and it was treated with a fixed prosthesis on top of it. They basically sutured the prosthesis over the conjunctiva, over the exposure, to close the exposure. Instead of treating the exposure, they did a shortcut. And then because it was not there was a lot of volume loss, and they put an additional prosthesis on top of the existing prosthesis. So he had like a double decker prosthesis on top. So then we took him up for surgery. It was a very messy surgery. It took almost an hour to take out the whatever implant that they had put inside. It was, I think, it was difficult to say what it was, but I had to take it piecemeal. It most likely was a porous PMMA, and it was, there is a lot of ingrowth into the vascular ingrowth into the implant, and it was a very messy surgery. It took about 1.5 hours just to take out everything that was there. So at that point of time, I did not put any implant. I just waited for the socket to heal. So this is what we removed at the end. There were many smaller pieces which we couldn't salvage towards the thing, and I put it for the so it came out to be a MRSA, the organism that was growing in the socket. So once the socket settled down for about 4 to 6 weeks later, we went in, because the volume correction had to be done, and we couldn't put a large enough implant, and there was severely contracted socket, so there is a lot of scarring within the tenons capsule. So even if you put a big implant, it will not stay. So what we decided was we'll put a inophthalmic wedge, and we put a smaller implant than what we would usually put in a new socket. So this is inophthalmic wedge. So we put the inophthalmic wedge below the periorbita, and to increase the volume, and then we put a little smaller implant. I think this was a 16 millimeter implant. So implant, so that we then after that we put a mucous membrane grafting for the lower lid, the surface augmentation, and for phonics forming sutures for both upper as well as lower phonics. So this is about 3 months out after the first surgery. So he got a reasonably, and he's pretty happy about the process. And the movement is not that good because of course there is so much scarring, but at least when he's looking straight, he's fine. So this is another case which I had done enucleation about a year before this for retinoblastoma. So her main complaint was that the ocularist actually told me that I am not able to fit in a good prosthesis for this patient because it's moving sideways. So when we remove the implant, we see that you can see that the lateral fornix is very deep, and when we did the imaging, we see that it is moved medially. So I think I have two, three more slides. So it's moved medially. So when we moved medially, what we decided was that if we remove the implant and put it in the right place, it'll again go back to the same place, because wherever there is least resistance, it will go back to the same place. So again, in this case, we put a inophthalmic wedge, which would push the implant on the laterally, because the thickness is more on the medial side. So this comes in the right as well as the left inophthalmic wedge. So we put a right inophthalmic wedge into the implant so that it pushes the implant laterally, and sure enough, with that we could put a reasonably we could get that processes in the alignment correctly because of that. So this is another case where he had a painful blind eye because of glaucoma, absolute glaucoma, and we did a surgery, and it was fairly uneventful. Nothing happened. Patient was very happy, and 2 weeks later he had staining at stools, and then he came to the OPD with outpatient clinic like this. So it is about and it's sudden. It was not there the previous day. It is because of the staining in stool. So he had this. He was putting pressure on that, and it just bled. And he was not even on blood thinners or anything, but that's what he came with. And then we see that we did the imaging. We can see that the implant has been is very anterior, and there is a retro implant hemorrhage. There's a hemorrhage at the back. So then we had to open him up, and then you had to open it up and take out the blood. So this is just a few weeks back. So I don't have the post-op outcome. So basically it's there is a implant hemorrhage at the back. So take-home message is basically secondary socket reconstructions are challenging, but can be satisfying if you do it in a very stepwise manner. And volume correction as well as surface augmentation is required. Initially, I wanted to do everything at one stage, but as I have do more and more of these sockets, I realized that stage procedures is very important. You do one step at a time, because the variables are reduced. And then managing the patient expectation is also very important, because they come with after a lot of surgeries, and they think they want to get back to how they were before, and it is very difficult sometimes to their expectations are very high. So we have to manage them and tell them about what all things what all things to expect and post surgery, so that the post surgery recovery is better taken care of. Thank you very much.
Thank you very much, Raghu.